Most experienced person to talk about the minimal residual disease is from the University of Navarra in Pamplona, Bruno.
Well, good morning. I would like to thank the organizers for the kind invitation to be in Paris this morning and to talk about minimal residual disease. Now, this slide is not here by mistake. ISS, LDH, and cytogenetics, they are all used for the revised ISS, for accurate risk stratification in myeloma. And I would say that even though treatment decisions are not typically made according to patient risk or stage, ISS is considered as mandatory for every single newly diagnosed patient. Why? Because it's fast, simple, and extremely informative. And it's quite interesting because in the same issue of the JCO, Brian Walker and his colleagues have also published on an alternative approach for the ISS based on the inclusion of mutations. And I would also say that even though this does not seem to improve ISS risk stratification, and also that even though there are only a few mutations that might be targetable, and we still don't know yet the clinical benefit of targeting those mutations, nowadays we wouldn't want to know the mutation profile of a newly diagnosed patient. Why? Because it's information, because it's knowledge. Then we wouldn't want to know the quality of a patient response to therapy. And in fact, in myeloma, CR is considered as a typical clinical endpoint and certainly one of the most powerful prognostic markers. However, what we have been emphasizing during the last, I would say, 10 years is that the true value of CR relies on the MRD status. And in fact, CR without MRD negativity is no better than VGPR or partial response. And I would even say that with a very long follow-up and based in a large number of patients, only MRD negativity, even with a very low sensitive 4-color flow assay, gives some probability of long-term survival. It's not that CR is not clinically meaningful, it's that MRD negativity supersedes the clinical benefit of complete response. In transplant-eligible, transplant-ineligible patients, irrespectively of the ISS, irrespectively of FISH cytogenetics. And this is important because it might be that with sensitive MRD monitoring, MRD negativity may equal survival of high-risk and standard-risk patients. Then, which technique or which techniques to monitor MRD? And I would say that, fortunately, in myeloma, we have plenty of techniques to monitor MRD. Cellular clonality in the bone marrow, either by flow, ASO, or digital PCR, next-gen sequencing, and also, as Dr. Terpus has alluded before, imaging techniques such as, for example, PET-CT. Dr. Martinez Lopez from the Spanish group has published in 2014 what was at the time the first experience using NGS to monitor MRD in myeloma, and he has shown that more than half of patients in CR after stem cell transplantation remained MRD positive, and the outcome of these patients is completely different as compared to the outcome of patients MRD negative. I would even say this is a complete new definition of CR. Importantly, these findings have been reproduced very recently in the last ASH meeting by the IFM. Dr. Aveloiseau has shown that after transplant and then consolidation and then maintenance, still around 40% of patients in CR remain MRD positive by NGS, and again their outcome is completely different as compared to the outcome of patients with an MRD negativity. And all of these are in CR. This is a new definition of CR. Then, is NGS superior to flow? I would say that it depends on how you compare it. Certainly, if you compare NGS versus 4-color first-generation flow, even though there is a good correlation, even though there are some discordant patients that are positive by immunophenotype, negative by molecular, there is certainly a significant fraction of patients that are positive by NGS and negative by 4-color flow. And it's even possible to see that there are two patterns of discordance. Patients with high MRD levels, most likely with atypical phenotypes, and then patients with ultra-low MRD levels for which the 4-color assay didn't add the sensitivity to detect. I would say that first-generation flow is now very much in the past, and in fact, during the last 2 years, different groups have been reporting their experience using 1 log more sensitive second-generation flow. And with 1 log more sensitivity, it's actually possible to identify patients that have MRD at 10 to the minus 5, and as you can see, their outcome is in fact identical as compared to patients with MRD at 10 to the minus 4 or higher. In other words, it's clinically meaningful. And certainly, their outcome is significantly inferior as compared to MRD negative. However, and even though these are elderly patients and there is no further treatment after the moment of MRD assessment, the prediction of risk for MRD negative patients using a second-generation flow assay is not yet powerful enough. And this is why there was the need for next-generation flow. I'll skip the details of the slide. I'll just mention that it was designed and developed to reach a limit of detection in the range of 2.5 per 10 to the minus 6. In fact, nowadays, with over 1,000 patients being tested with the NGF assay, we can say that the accurate limit of quantitation is in the range of 10 to the minus 6 for approximately 85% of the patients, and the limit of detection is in the range of 10 to the minus 6 for virtually all myeloma patients, younger or elderly patients. The method also comes with a software that allows for automated analysis, and as you can see in the slide, automated analysis as compared to expert manual analysis shows a rate of concordance of 100 out of 102 patients. Then, if we compare next-generation sequencing versus next-generation flow, I would say that with a small number of patients, that next-generation flow performs at least in the similar range of sensitivity and specificity as compared to the molecular method. However, and as many in the room are well aware and have mentioned plenty of times throughout the last years, myeloma is a patchy disease. And this is an example of a patient that was MRD negative after induction, and as you can see, after high-dose therapy, there is the emergence of 2 well-defined chemoresistant clones with a lambda light chain restriction. This is a limitation that applies both for flow and for sequencing. How can we overcome this limitation? We believe there are 2 approaches, most likely complementary. One is sequential MRD monitoring, In other words, the clinical impact of sustained MRD negativity, which is here illustrated in elderly patients even without further therapy after the moment of MRD assessment. This would be one approach. The second would be to complement cellular techniques with imaging techniques. And here I refer to the data again from the IFM. Dr. Moreau has shown last year in ASH that patients with a negative PET-CT and a negative MRD by flow after therapy, they have a projected 3-year PFS rate of approximately 90%. In summary, I would say that PET-CT will definitely play an important role in the future, though we might need more studies to fully understand its value. And I would dare to say that both NGF and NGS are ready for prime-time MRD monitoring in myeloma. It's important to know that each technique has its own set of advantages and disadvantages, and therefore there isn't a single technique that is 100% perfect. I would also say that even though the Spanish group was in fact one of the first to report about the value of fluorescent PCR, then ASO-PCR, and even next-generation sequencing, it's no secret that we have been particularly implicated in the development of flow. And the reason is because, providing there is the same sensitivity and the assays are well standardized and validated, because of global cell characterization. Why global cell characterization? Because everywhere you go, there is always one example of a patient with a persistent M protein that is progression-free and off therapy after many years. It's important to understand these patients so we can prospectively identify them. In fact, I think all of us in the room have been delighted to see how much we have learned over the last 3 to 5 years about clonal evolution, clonal selection, and its implication particularly about the disease pathogenesis, as well as the disease becomes refractory to the majority of the compounds. But in fact, within the Spanish group, we have always thought that perhaps one of the most important pieces of the puzzle was not being studied, which is the MRD cell. In other words, in-depth research about MRD clones to understand the mechanisms behind chemoresistance. In fact, during the last 1.5 years, we have shown that there is clonal selection already at the MRD stage, because there might be clonal selection. In some patients, there are different genetic profiles when we compare the myeloma cell at diagnosis versus at MRD at the individual patient level. Because there might be the different genetic profiles, there will be a different transcriptome, and because there is a different transcriptome, there is different protein expression. It might even be some potential therapeutic targets. This is the second time I'm showing this slide, but now the title is different, and so is the message. Here the message is that while the outcome might be similar for both standard and high-risk patients if they reach MRD negativity, the same does not apply if they remain MRD positive. In other words, prediction of outcomes based on MRD levels, but also based on the unique genetic features of MRD clones. Then, global cell characterization to perform immediate sample quality control, as well as immune profiling. And in fact, we have recently reported that even by using a single 8-color antibody combination, it was possible to develop individual patient immune signatures that may cluster in different areas because of different immune profiles, and these may be associated with a different survival, irrespectively if the patient was MRD negative or positive after therapy. In fact, we believe this should be a focus of more research in the future to understand if there is a role for immune surveillance in controlling persistent MRD after therapy. Then we need to understand how to discriminate among patients with undetectable MRD, those that may experience late relapses from those that would potentially experience long-term survival. We believe that here again there is a true need for MRD monitoring during follow-up. And both the Spanish as well as the Italian group have shown that if the patient is MRD negative after therapy, if there is MRD reappearance, this most likely will precede a biologic and then a clinical relapse. In fact, not only at follow-up, but MRD has shown to be informative, I would say, across all stages of the patient clinical course. I believe many of you are already well familiar with this type of slides, so I'm not going to go over all the stages. I would rather focus on a single stage, after maintenance therapy. And here again, I use the data reported by Dr. Aveloazo, in which he has shown that if the patient remains MRD positive after maintenance, irrespectively of the MRD levels, either it's 10 to the minus 4, 10 to the minus 5, or even 10 to the minus 6, there is an immediate impact in terms of progression-free survival. Then I would say that we have entered in a new era of next-generation monitoring in myeloma. Now we can finally detect those few cells that precede biological and clinical relapses among patients in complete response. In fact, you can see in this slide that for this particular ultra-chemoresistant patient, with the exception of the moment after induction, the patient would have been considered as MRD negative at all times by first-generation flow. And even using a second-generation more sensitive assay, after consolidation, the patient would have been considered as MRD negative. In fact, we are now learning from some mistakes from the past. Whereas in the past we have said that there was a significant fraction of patients that turned from MRD positive after induction into MRD negative after high-dose therapy, stem cell transplantation, now we see that in fact the majority of the patients remain MRD positive. MRD levels may decrease up to 10 to the minus 5 or 10 to the minus 6, but the patients remain MRD positive. And now the question is, what can you do with all these MRD positive patients? And in fact, the sentences in this slide are not statements, they are questions for you and for the discussion. What to do in patients with persistent MRD positivity after 2 years of state-of-the-art therapy in 2016. To stop treatment because it could be an indolent clone, to continue because it will control the residual clone, or to change drugs because the same cannot eradicate nor control the persistent MRD. But alternative yet important questions can also be made for patients with a continuous MRD negativity after 2 years of state-of-the-art therapy. What is the best option in 2016? To continue because of late relapses, perhaps to stop therapy for a period of time, potentially 3-5 years of treatment-free interval, or even to stop therapy at all because many of the patients, potentially those with a sustained MRD negativity, might in fact experience operational cure. This was the last slide. Thank you for your attention.